So colleagues, our today's topic is pit and fissure sealing. As for me, it is very interesting and very important topic. As told Thomas More, a very famous English person, it is a wise man's part rather to avoid sickness than to wish for medicines. And pit and fissure sealing is a part of this phrase. Our today's conversation will have next chapters: introduction, then historical background. We will stop at definitions. Then we will talk about fissure's classification. About formation pits and fissures. We will classify sealants. We will talk about indications and contraindications of pits and fissures sealing. About patient selections. Then we will discuss advantages and disadvantages of sealing. Talk about sealing recommendations, sealing procedure, and we will make conclusion. Introduction. With the introduction of fluorides, definitely caries is on decline. But approximately 90% of all caries lesions in the mouth occur on the occlusal surfaces of the posterior teeth, premolars and molars. These surfaces represent 12% of the total number of tooth surfaces, so the occlusal surfaces are approximately 8 times as vulnerable as all the other smooth surfaces. When I prepared this presentation for you, I found this very interesting article, and this diagram is part of this article, and they are shown distribution according distribution of caries experience according different surfaces, and as can you see, 61% of dental caries is occlusal caries or first class caries by Black classification. And this diagram shows that pit and fissures sealing is very important action to decrease caries in oral cavity in human population. Caries pattern has become more tooth and surface specific. According to Swanko and Bernal, at age 17 years, occlusal caries for first molars is 70%. 50% for second molars and 14% for premolars. What about history? What is historical background of sealing? At the end of 19th century, maybe not at the end, but at the middle of 19th century, author stated that decay was inevitable and that obliteration of the fissures could prevent its occurrence. In 1995, Wilson described the use of oxyphosphate cement to seal fissures, introduced the concept of preventing dental caries in these fissures using a physical barrier, zinc phosphate. In 1923, Hayat proposed prophylactic odontotomy. It is procedure when non-carious fissures were prepared and restored with silver amalgam. Bodecker in 1929 proposed the technique called as fissure eradication. Fissure is smoothened but not restored. In 1939, Gore used polymers as sealant. 1942, Klein and Knudson used ammoniacal silver nitrate to treat pit and fissure. In 1955, Bonnecourt introduced of first pit and fissure sealant and reported the use of acid to etch the enamel surface prior to applying acrylic resin. And the first specific pit and fissure sealer was NuvaSeal. The acid etch technique allowed for sufficient bonding between the resin material and the enamel and provided the basis for further development of effective sealant materials. In 1965, Cueto and Bonnecourt was published first paper on pit and fissure published on pit and fissure, and in 1967 utilized cyanoacrylate as sealant material. In 1965, Bowen and co-authors established and proposed bismuth resin for sealing. This material called Bowen's resin. It was chemical product of bisphenol A and glycidyl methacrylate. And in 1976, Council of Dental Materials of the American Dental Association designated sealants as a safe and effective means of preventing pit and fissure caries. Next chapter of our today's lecture: definitions. If we will take the free dictionary and ask question about medical, in chapter medical dictionary, what does it mean fissure, we will see a few definitions, but in a medical and in a dental meaning, fissure, it is a deep cleft in the surface of a tooth, usually due to imperfect fusion of the enamel of the adjoining dental lobes. And notice that it can be treated with a dental sealant to decrease a risk of caries. But what does it mean, pit? The same dictionary gives us a few definitions. That pit, it is a natural hollow or depression in the body or an organ. Keyword is a natural. Or a small indented scar left in the skin by a smallpox or other eruptive disease. And it will be pathology. But we are interested in dental definition. And dental definition tells us that pit, it is a sharp point in depression in the enamel surface of a tooth, caused by a fully or incomplete calcification or formed by the confluent point of two or more lobes of enamel. Then, let's look for term sealing. In common meaning, sealing means using an adhesive agent to close or secure something. In medical chapter of this dictionary, there are no term sealing, but the present term seal. And this term told us that seal is a tight closure or to effect a tight closure. Please don't confuse with filling. Terms sealing and filling. What does it mean in the medical meaning term filling? First of all, it is the material inserted into a prepared tooth cavity, usually gold, amalgam cement, or a synthetic resin, or the process of inserting, condensing, shaping, and finishing a filling in a prepared tooth cavity or oral channel. Please don't confuse terms filling and sealing. I'm sorry. But in this dictionary, in medical chapter, the present terms term pit and fissure sealant. What does it mean? This term means that pit and fissure sealant, it is preventive resin material applied to pit and fissure dental areas to prevent caries. But as for me, this definition is so old because nowadays pit and fissure sealants are not only resin but glass ionomers too. Please notice that, as states Simonsen in 1978, sealant has been described as a material placed into the pits and fissures of caries-susceptible teeth that micromechanically bonds to the tooth, preventing access by cariosogenic bacteria to their source of nutrients. And application and mechanical bonding of a resin material to an acid-etched enamel surface. So let's go to the next chapter, fissures classification. First of all, we need differ smooth surfaces and fissures. And we need to understand how can we prevent caries in a smooth surfaces. We prevent caries in a smooth surfaces by using of topical fluoride instead of pits and fissures caries prevention. We need to use dental sealants. So what types of fissures? They are known. According to Nagano classification, proposed in 1960, there are 5 types of fissures based on the alphabetical description of shape. There are shown 5 types of fissures, and they are present next types. U-type. It is type of fissure where almost the same width from top to bottom. Next type, V-type. It is wide at top and gradually narrowing towards the bottom. I-type. It is type with extremely narrow slit. IK type. Type of fissure with extremely narrow slit with a larger space at bottom. And inverted Y type. Type with narrow slit and wide bottom, similar to Y letter but inverted. And I would like you to understand that the shallow white V and U-shaped fissures tend to be self-cleaning and somewhat caries resistant. Instead of deep, narrow eye-shaped fissures are quite constricted and resemble a bottleneck. But I and K fissures type are more caries susceptible. So, how pits and fissures are formed? We know that during the formation of teeth, the anterior teeth grow first very quickly, escaping from pits and fissures. But this is not the case with the posterior teeth. And tooth surface gets fissures when growing processes on teeth. Inappropriate fusion of enamel in the surface area causes a deep linear depression. Pits are also formed because of grooves. Pits are found at the ends of groove cross sections. The root cause for all these pits and fissures is not folding and inappropriate spreading of enamel of teeth. And what histopathology of pit and fissure caries? At the third stage, inclines forming the walls of the fissure, affected by caries first and not the base. Caries at the orifice of fissure occurs as two independent bilateral lesions. After that, lesion progresses and involves the fissure walls. Next step, coalesce into a single lesion at the base of the fissure. Then, on reaching the dental enamel junction, lesion spreads laterally. And as a result, cavitation due to loss of mineral and structural support from adjacent affected enamel and dentine. Please look at the scanning electron micrograph of occlusal pits and fissures. We can see deep fissures and multiple pits in the occlusal surface of molar. And this scanning electron micrograph, we can see comparison between fissure and toothbrush and toothbrush. And as can you see, even the smallest toothbrush cannot reach the bottom of fissure. Now let's talk about classification of sealants. What classifications of sealants are present? First of all, we divide sealants according time of development into early materials and newer materials. What does it mean, early materials? Early materials for dental sealing. It is materials proposed and developed from 1904 till 1950. First of all, it is very famous and very widespread silver nitrate. When I prepared this presentation, I found very interesting article named "Silver, the Magic Bullet in Dentistry." They are shown in this article. Was shown development of using silver in medicine, beginning from 1900, when silver was used as a suture material. Then, in 1990, Alexander used silver nitrate eye drops to prevent ophthalmia neonatorum in newborns. Then, Crede was the first physician to use colloidal silver for wound asepsis. Then, Crozius in 1890s used silver to treat born wounds. And then Vonnegut was the first person to attribute the application of silver to its function as an antimicrobial agent. How we use silver nitrate? We need mixed two liquids, but not in our working table, but in a tooth of patient. As a result, in a tooth surface, we will create silver pots, and in that way we will get antimicrobial and karyostatic effect. But what is disadvantage of this method? Of course, disadvantage is not aesthetic appearance of a silvered teeth. Then was proposed zinc phosphate and amalgam for prophylactic odontotomy method. This method was proposed by Hayat in 1923 and consists of filling the fissures with silver or copper oxycement as soon as it is erupted into oral cavity and later when they are fully erupted, but preparing a small occlusal cavity and filling it with amalgam. As can you understand, no longer advocated as preventive measure this method. And to early material and newer filling materials from 1996 till present day. Of course, first of all, it is cyanoacrylates, urethane resins, bisgma resins, glass ionomer cements, and resin-modified glass ionomer cements. What classification according generations? According generations, sealing materials are divided into 3 generations. First generation, it is sealers polymerized with ultraviolet light. Its wavelengths of 365 nanometers, and it is cyanoacrylate based material. In 1976, these materials classified as accepted by American Dental Association. And examples of these materials can be Alpha Seal or Nova Seal. But was third generation materials was failed? They was failed due to excessive absorbed ultraviolet light, and as a result prevented complete polymerization of sealant as its depth and consistency of wavelengths from the ultraviolet light source, and the potential for a retinal damage with long-term exposure to ultraviolet light. Because there was developed second generation of sealers. Differences, better formulations, maybe self-cored or chemically cored, mostly unifilled resin. Get better retention clinically than first generation sealants, and it is a very important point. Examples of sealers from second generation is concise white sealant system from 3M company, 3M SP company, and Dalton Pit and Fissure sealant from Dentsply company. And third generation. Sealants of third generation are light cured by visible blue light at a wavelength of 430 nanometers till 490 nanometers. maybe unfilled or filled. Initiator for polymerizing process camphoroquinone. Examples of this material is light-cured Dalton, light-cured white sealant, and fluoroshield. So, advantages of third generation sealants. No mixing of resin needed. Eliminates incorporation of air bubbles. And viscosity remains constant. Net classification based on filler content. And according to this sign, sealants are divided into unfilled, free of fillers. Features of this group: flow is better, retention is more, abrade rapidly. Example of this sealant is a product of 3M Espa company, a light cured white sealant, concise. And filled. These materials need for occlusal adjustments, but more resistant to wear. An example of this material is a Prisma Shield sealant from Dentsply Sirona company. Classification based on translucency. Sealers can be clear, and features of this group are aesthetic but difficult to detect at recall examination. Better flow than tinted or opaque. More easily appreciated by the patient. And tinted or opaque can be easily identified. Like Dalton product, and we can notice that we can identify it easily in a tooth surface material of this type. And colored sealants. This group of materials easy to see during placement, easy to see during recall checkup, and example of this group sealants is Clean Pro sealant with pink color. And classification based on curing. According to this sign, all sealants are divided into autopolymerizing, Features of this type of sealants is better retention, like 88% sets by exothermic reaction, and light cure. This group of materials has worse retention, only 75%. And what requirements for ideal sealing material? We know. First of all, a viscosity allowing penetration into deep and narrow fissures even in the maxillary teeth. Adequate working time. Of course, a rapid cure. A good and prolonged adhesion. A low sorption and solubility. Minimum irritation to tissues. Not toxical and allergy influence. Of course, resistance to wear. And of course, karyostatic action. Let's go to the next our chapter. Indications and contraindications for pit and fissure sealing. What indication for dental sealants? First of all, pit and fissure sealants are especially useful for selected patients through the caries active period. At its age from 6 till 15 years old. And sealants are indicated for teeth with deep pits and fissures, preferably in recently erupted teeth, not more than 4 years after eruption. Sealants should be used as part of a prevention program that includes the use of fluorides, dietary considerations, plaque control, and regular dental examinations. Then, next indications. Carious occlusal anatomy. If pits or fissures are separated by transverse ridge, a sound pit or fissure may be sealed. Carious pits or fissures, deep, narrow pits and fissures. General carious activity, mild, not more, many occlusal lesions, and few proximal lesions. And first of all, recently erupted teeth. But what contraindications to dental sealants? First contraindication, a lack of pits and fissures. Why? No pits, no fissures, of course, no sealing. Apparent occlusal decay. If decay is present, it will be not sealing but filling. Interproximal decay. Insufficient eruption of a tooth. Soon to be lost primary teeth. Poor patient cooperation in the dental chair. Why? Because we cannot have absolutely dry and clear dental surface, occlusal surface in that case. And high general caries activity is contraindication to sealing. Sound brought valvular spits and fissures. Teeth without caries, free for 4 years after eruption or longer. Rampant caries decay. Interproximal lesions. And if occlusal surface is already carious. In that case, we will do not sealing but filling. And if tooth present in mouth for many years and there is no evidence of decay. Next chapter, patient selections. We have to choose not only teeth for sealing, but patients too. According to Simonson, patient selection based on caries risk is divided into 3 groups. First group, caries-free patient judged to be with no risk of decay. It is first group, patient selection based on caries risk. Second group, patients judged to be at moderate risk of decay. And third group, patients with rampant caries at a high risk of decay. Then, patient selection based on clinical judgment. First of all, it is age of the patient. Then, oral hygiene of patient. Of course, familial and individual history of dental caries. Of course, tooth type and morphology. And dietary habits. It is patient selection based on clinical judgment. And of course, fluoride environment and history. But colleagues, please Notice main rule for patient selection based on clinical judgment. Select the teeth that are more likely to be decayed. Then patient selection based on a age. First group from 3 to 4 years old for primary tooth. Next group 6 to 7 years for first permanent molars sealing. And 11 to 13 years for second permanent molars and premolars. And now shortly about sealants on primary teeth. Sealants not widely used on primary teeth for two reasons. First one, moisture control. Why? Because in young patients, there as usual poor patient cooperation and of course isolation of teeth from moisture is extremely difficult as usual. And second reason, limited lifespan of the tooth. Because of cost effectiveness of sealant placement considered. And if second primary molar reached age 6 without caries, another 4-6 years before exfoliation. And if child has caries on occlusal caries on one of the second primary molar, we must seal the contralateral molar, symmetrical molar, to prevent caries. We talked about patient selection, and now let's talk about advantages and disadvantages. Pit and fissure sealing. Advantages of sealing. It is a non-invasive technique. It is a very big advantage. Sealing of pits and fissures prevents tooth decay. Of course. Fluoride release from fluoridated sealants can confer protection to adjoining areas. Sealants can be used at the commonly level for prevention of caries. But what disadvantages of this procedure? Sometimes we can get adverse reaction, like allergy to resin. Then, caries susceptibility of etched enamel. Economic feasibility. Inadvertent placement or caries sites. Detection of lost sealant. Technique sensitivity. What Sealing recommendations. Recommendations from American Association of Pediatric Dentistry. Sealants should be placed into pit and fissures of teeth based upon the patient's caries risk, not the patient's age or time lapse since tooth eruption. Sealants should be placed on surfaces judged to be at high risk or surfaces that already exhibit insufficient lesions to inhibit lesion progression. Follow-up care, as with all dental treatment, is recommended. Next recommendation of American Association of Preventive Dentistry. Sealant placement should include careful cleaning of pit and fissures without removal of any appreciable enamel. Some circumferences may indicate use of a minimal enameloplasty technique. We know this approach like operative sealing. A low viscosity hydrophilic material bonding layer as part of or under the actual sealants is recommended for long-term retention and effectiveness. Glass ionomer materials could be used as traditional sealants. And European Association of Prevention Dentistry developed guidelines about sealing. And patient and tooth selection should be based on the following: children and young people with medical, physical, or intellectual impairment. Children and young people with signs of acute caries activity. All susceptible pit and fissure sites should be considered for fissure sealing, including the buccal fissures of permanent molars. Please don't forget about buccal fissures. Then guidelines from European Association of Prevention Dentistry. Children and young people with no signs of caries activity, only deeply fissured, extremely plaque-retaining fissures, and thus potentially susceptible surfaces should be considered for sealing. It should be mentioned that all children, irrespective of caries activity, should be regularly monitored for any change in risk factors and or clinical or radiographic evidence of a change in their caries status. And in 1968, at an American Dental Association sponsored conference on clinical testing of cariostatic agents, the criteria for detection and diagnosis of pit and fissure lesions was developed. I found original article that criteria was published at Journal of American Dental Association, and that criteria looks like this table. And according to that recommendation, diagnosis of pit and fissure caries based on tactile evaluation with Explorer, visual assessment of animal appearance, and radiographically, evaluation of occlusal caries can be done. And according to that recommendation was developed ICDAS, International Caries Detection and Assessment System. It is a caries detection and assessment system that has been introduced to measure the stages of the caries process rather than just the decayed stage. This system is based on detailed visual examination of clean tooth surfaces, careful drying of the surface lesion in question is considered important for identifying early lesions. This system measures 6 stages of the caries process, ranging from early clinical visible changes in enamel to extensive cavitation. And this system has shown a good association between the scores for caries in enamel and dentine and histological measurement. And according to this guideline, the use of fissure sealant is recommended for early, non-cavitated caries lesions, the definition of which corresponds with ICDAS second codes 1 and 2. 1 and 2. As can you see, it is very detailed scheme. You can find it yourself and to learn this classification system. And now, let's talk about sealing procedure. But first of all, I would like to tell you important information. Always read and carefully follow the manufacturer's instructions when applying dental sealants. Application technique and etching times may vary between manufacturers. For example, some manufacturers discourage the use of a polishing paste that contains fluoride, but other manufacturers don't consider fluoride polishing pastes to be contraindicated. And Please notice factors in sealant retention. Moisture contamination is the primary cause of failure of sealant retention. It is bad retention. Inadequate etching is also a factor in loss of sealant retention. Dental sealants should be examined at each recall visit to be certain that the sealant material has not been partially or totally lost. When dental sealants are properly placed, it is not uncommon for them to last 5 to 10 years. And let's talk step by step about sealing procedure. And first step, of course, select teeth to be sealed. And of course, isolate from moisture. Second step, preparing the tooth surface. It is absolutely necessary to remove plaque and debris from the enamel and the pit fissures of the tooth prior to sealant placement. And we can use bristle brush or a rubber cup with pumice. But Goldstein in 1995 proposed air polishing device Profijet using sodium bicarbonate particles to clean tooth surface. This device, of course, increased cost and complex procedure, but air polishing followed by acid etching increased bond strength. And after cleaning, please notice the fissures in premolars. There are clearly visible differences before and after second step of sealing procedure. Third step, you must wash and dry the tooth surface to eliminate pumice and or sodium bicarbonate. Fourth step, etching. For etching, we use etching solution 30 or to 40% phosphoric acid solution. We need to avoid spillage into the interproximal region to avoid gingival irritation. And colleagues notice that gel form preferred over liquid because of gel form provide better control. Sometimes can observe skipping effect. When very viscous gel etchant we use, does not wet the surface uniformly and completely, and a result, an etched area evident after washing and drying. If we will notice that areas, we must re-etching that surfaces. Re-etching is necessary. Bone core in 1955 proposed to use 85% phosphoric acid for 60 seconds for etching enamel. Another scientist, Gwynedd, in 1973, established that primary enamel prismless nature requiring double etching time, 120 seconds. But Simonsen in 1978 compared retention on primary molar of 120 seconds etching time versus 60 seconds and not found differences in sealant retention. In 1979, Simonsen's decreased the etch time for primary molars and established that decreasing of etching time decreased chance of contamination during etching, and established that shorter etching time for more acceptable for 3-4-year-old patients. Wegener in 1996 currently recommended etching time 20 seconds for permanent teeth and 30 seconds for primary teeth. Duggal in 1997 compared different etching time of 15, 30, 45 and 60 seconds on retention of Pitt and Fissure sealants and concluded that different etching times don't affect retention on Pitt and Fissure molars or primary second molar. On permanent first molar or primary second molars. And why is prolonged etching time necessary for primary teeth? Primary enamel has low mineral component, high internal pore volume, more exogenous organic material, and more prismless enamel, according Aripa evaluation published in 1966. And according to American Dental Association Symposium in 1991, etching time for primary teeth must be 30 seconds, and for permanent teeth is 20 seconds. Next, fifth step, rinse and dry the tooth surface. We must rinse with water for 20 to 30 seconds and dry it for 15 seconds. Use air that is oil-free. And as a result, we will get etched enamel, frothy white enamel appearance. And very important, doctors, to provide protection of etched enamel from saliva contamination. It is considered as the key to success. If salivary contamination occurs, we must repeat all procedures from first step. And as a result of success in the fifth step, we will get frostly white appearance. Next step, bonding agent application. As was established by Feigl and co-authors in 1993, use of bonding agent increased sealant retention even when salivary contamination occurred. The same author, in 1998, recommends use of dentine bonding agent when isolation not possible, lack of patient cooperation on buccal surface of molars. Next, seventh step, sealant application. We need to apply without removing applicator from enamel surface to avoid bubbles. We must be careful not to incorporate air bubbles in the material. And then light cord 20-30 seconds. If necessary, fill bubbles or voids with additional sealant. As a result of seventh step, our teeth will look like this picture. And eighth step, light cure. Then, next step, sealant evaluation. The sealant should be evaluated visually and with an explorer. You must check for occlusal height points using articulal paper. And excess must be removed with small round bore. And let's compare before and after sealing procedure. And please don't forget about next step, sealant re-evaluation. Periodic recall, it is check for loss of material, caries development, and any voids. This step need for reapplication highest during the first 6 months after placement. And statistically, from 5 to 10% of sealant need to be repaired or replaced yearly. And now video about sealing procedure.
Coffee cup or brush. If required, pumice slurry may also be used. Then isolate tooth using cotton wool, dry tip, saliva ejector, with rubber dam if possible. Then tooth surface should be etched with 37% phosphoric acid. Wash for 15 seconds. Dry for 15 seconds. Use a bonding agent if surface could potentially become contaminated with saliva. Then light cure for 15 seconds. Deposit pit and fissure sealant resin covering all the pit and fissures in a very thin layer. A small excavator or periodontal probe are useful to spread over the pit and fissure and remove any air bubbles if formed. Light cure for 15 seconds. Check adhesion immediately and monitor in the future periodically.
And at the end of our today's meeting, conclusion. To make significant gain in decreasing caries in children, it is necessary for dental professionals to educate and inform the general public, parents, and physicians about cost effectiveness and caries preventive benefits of sealants. Thank you, doctors, for your kind attention.